Hello, everybody. Thank you for coming to the symposium. Thanks for coming back from lunch. I'm going to be the starter-upper after lunch, or at least a little snack. I'll be leading in for Dr. Benz. I'm one of the kind of older guys from OCR, no jacket. So my conversation today with you is going to be kind of a conceptual discussion. I know you guys have had some pretty intense detailed discussions, and there'll be some to follow. But mine, you can all kind of relax a little bit. I'm just going to have a conversation with you. I'd like to kind of convince you of some of my ideas and some preconceptions so that you can use those in the situations where you have to deal with the interface between bleeding and upper limb trauma. I'm Satoru Chamberlain, one of the hand and upper limb surgeons at the Orthopaedic Center of the Rockies. And my discussion today will really be about trauma, ischemia, and the upper limb. I really just want you to have a takeaway of 4 things, 2 discussion points and 2 concepts. And really the reason for my discussion today is really to contrast the use of a tourniquet in the trauma or in the field with our aims and goals in terms of reconstruction of the upper limb. There's many reasons to use a tourniquet in the field. A lot of those have been adapted from multiple mass trauma situations or military situations. It's become very trendy, very popular to carry a tourniquet and put it on to save somebody's life. And there's certainly strong reasons. Self-rescue. In the situation of military and even some urban warfare situations, being able to rescue yourself after major catastrophic bleeding is something where the tourniquet has been shown to be very valuable and saves lives. Military actions, of course. Military personnel can use tourniquets to stabilize patients and transfer them. Civilian mass casualties. More and more we're in a situation where we have to be mindful of mass shootings, explosions, multiple casualties. How do we triage these patients? How do we make choices? How do we make the appropriate judgments in those very awkward, complex, and dangerous situations? And more in our big cities, and big cities all the way around the world, there are situations where we have armed gangs. And in that situation, it's sort of a minor military situation where the use of tourniquets, stabilization, and transport has been shown to be very effective at saving lives. But for me today, we're talking about a slightly separate situation. It's really the use of the tourniquet in a catastrophic hemorrhage situation in the upper limb. And what are the significances? So I'd like you to take away 2 concepts. Firstly, I want to talk about these 2 principles. Firstly, that hemorrhage is not the same as ischemia, and hemorrhage is not the same as infarction. That may seem self-evident, but when we look deeply into our own concepts, our precognitions, I think keeping that in mind, that hemorrhage is not synonymous with infarction. Secondly, I'd like to really go on a little bit of a journey with you and have you really examine the relative values of the upper limb and the lower limb. Hand surgeon, hand's pretty important. And in fact, what I want to show you today is that most of the function in the upper limb lives in the hand. The principles that I want you to take away is all the hand surgeons, you've seen a few of them today, and maybe you'll see some more. Our general principles are that pathological situations or trauma situations are devastating, catastrophic, universal. And so what we want to do in terms of reconstruction is decrease that zone of injury. That in any situation there's massive damage, destruction, and the aims of reconstruction and hand therapy in general is about specifically and appropriate reconstructing those tissues and little by little decrease the zone of injury. Let's not do anything that makes it worse. Let's try and decrease that zone of injury. Secondly, we have to have an overarching principle to make a decision in difficult situations. And we've all decided in the medical profession that we really do want to hold life in general as the highest pinnacle. So above all, we should save their lives. Sometimes we need to sacrifice their limb for the sake of their life, but if the life is secure, how do we protect the limb? So those are my discussions today, 2 points and 2 philosophies. So once again, I think this is a repetitive slide, but the things I want to take away really today is hemorrhage is not the same as ischemia, it's not the same as infarction. Upper limb function is mainly in the hand. And let's try and decrease the zone of injury. Let's not do anything bad. Let's save those structures that we can. Let's maximize the most valuable function in the upper limb. And we need some structure to make these value judgments. The reason we're having this discussion today is really based on this work. This was a study that was done in 2018. It's the so-called Texas Tourniquet study. And it was a study that was done in Texas where the use of tourniquets was adapted from military situations into urban situations in Texas. Multiple centers, over 1,000 patients were entered. 181 of them had tourniquets placed in the field, presumably by trained bystanders. And they found in this study that if that was implicated in the field, that they could save lives. And in fact, in the Texas Tourniquet study, the increase in lives saved was almost 5-fold. But when you look more deeply into the study, in the subtext of the study, we find that in that circumstance, the amputation rate in the upper limb rose twice. So if a layperson applies a tourniquet, in that situation, the risk of having an amputation in the upper limb doubles. This was then taken on. It was a monumental study for the adaptation of military practices into urban situations. It really supported the level 1, level 2 structure of our trauma care, and it was institutionalized by the Hartford Consensus. But there's some reasons for us to pause. There are some effects of tourniquets that we need to consider. And the hand surgeons, any of you that have worked in the operating room with the hand surgeons know that we do that a lot. We put those tourniquets on frequently, for me, 25 times per week. And in all those circumstances, I go through this checklist of the complications from those tourniquets. So we have to balance this enthusiasm for an institutionalized system of using tourniquets with the risks of those tourniquets. These are some specific points that we can talk through, and we can actually talk through those at the end if we need to. But I just want you to know that there is reason to pause in the upper limb before we apply a tourniquet. So this was popularized. The Obama administration dedicated a lot of money to the so-called Stop the Bleed program. And that's a program that's passed through the hospitals to our schools. And the whole concepts of using tourniquets and stopping the bleeding to save lives has been popularized. In fact, you can go to the website, you can get a t-shirt, you can get a nice little tourniquet, you can get sets. So very popular. Even in our very most established systems, CPR in gym class, airway, breathing, and circulation, has been replaced by the MARCH program. Massive hemorrhage, airway, respiration, circulation, hypothermia, has replaced the ABC system. So that really just emphasizes our violent society and the necessity to concentrate on control of massive hemorrhage. Today I'm going to talk about a slightly different situation. So the Stop the Bleed program, based on these 3 principles. And I'd like to emphasize that there's a 3-step program in Stop the Bleed. Firstly, to apply direct pressure. Put pressure directly on the bleeding part. And if we do that, then we can control the bleeding. I'll come back to that point. If that's not successful, then a strong compressive dressing. Applying direct pressure, applying a strong compressive dressing. And then if that doesn't work well, we can move on to a tourniquet. And in fact, in this study, if that doesn't work well, put another tourniquet on there. So that's the thing that I worry about, and we'll talk more about that. In fact, it's become so popular that you can go to the internet, you can buy a tourniquet, you can wear it every single day. You can put it on your clothes, take it with you, just in case somebody's bleeding. You can put it on their arm, works well. You can get different colored tourniquets. You can have them match your clothes. It can go with your scrubs. It can go into your bags. Easy. Is this really a form of bleeding control, or is it kind of an okay to go ahead and set up an ischemic situation in the upper limb. You can practice on yourself at home in the evening, applying tourniquet to your arm. And I would say as a sideline that if any of you are in a situation where you think you might want to apply a tourniquet, you should prejudge that. That is to say, if any of you have actually applied a tourniquet to your arm or to your leg and kept it on there for any particular time, it's extremely unpleasant. It's a catastrophic situation. It's a bad circumstance if you ever have to do that. So popularizing that as a technique for lay people gives me some pause. This is the counter-argument to it, though. This study really looked at lay people who were trained in the use of tourniquets. So this is a big study where military, police, and SWAT teams, as part of the Stop the Bleed program, trained lay people on how to use a tourniquet. Once again, the Stop the Bleed program incorporates those three tiers. But the take-home message, what did you learn today at your little course today? I learned how to use a tourniquet. They studied over 1,000 patients in this situation, and only 15% of trained lay people applied the tourniquet in a satisfactory position. 85% were incorrectly applied, in the wrong position, wrong pressure. So although we'd like it to be a rescue system we can use in the urban situation, even in trained individuals, we get it right about 15% of the time. This is the circumstance that I'm really going to talk to you about today. This is the common bread and butter of what happens to me when I'm on call and my peers. This is a traumatic, isolated injury in the upper limb, common. Patients are injured, there's a lot of bleeding, it's very catastrophic. There's torment and frustration in so many parts. We have to move these patients quickly through the system because we want to decrease that zone of injury. We want to treat them, we want to reconstruct their upper limb. But how do we do that? And is it necessary to use a tourniquet in this situation? This is the situation that we think of in terms of mass casualties, multiple people, multiple casualties. We don't have enough resources to take care of them. And in that situation, there is strong evidence that using a tourniquet, stabilizing patients, making judgments, value judgments, transporting patients actually saves lives. I'd say to you all, though, while you're watching this picture here, there's probably a few of those guys that could just be pressing on the wound. But let's just pause for a minute. How do we feel? What's our emotional attachment to bleeding, particularly in the upper limb? How do we feel about that? There's some people that faint at the sight of blood. There's some people that love it. Horror films. Our own bleeding reminds us of our mortality. When we're bleeding, we think we're going to die. Somebody else's blood. How about we get splashed with blood? I don't think that's so good. That's never a good situation. There's a risk. We don't like it very much. So let's just put a tourniquet on their arm. There's no blood. We don't have to worry about it. The patient's transported through the system. That's our emotional response, changing our judgments. And we need to be aware of those when we're making those judgments in those difficult situations. Let's talk a little bit about hemorrhage. So adequate cardiac function depends on adequate blood volume. And during the situation of bleeding, cardiac function decreases, perfusion of the vital organs is impaired, compensatory physiological events happen, patients eventually deteriorate, they go into shock, and if it's blood, if there is blood, there will be blood. If there is blood, then the patient's going to die. But hemorrhage is not the same as ischemia. Hemorrhage is a physiological event. Ischemia is an anatomical event. And we need to be careful that we understand those concepts. Hemorrhage is certainly not the same as infarction. Let's compare those. So hemorrhage is a physiological bleeding circumstance. That is to say, containment of the blood in the vessels has been disrupted. So there's physiological bleeding. It's a dynamic, physiological, time-sensitive change. It can result in systemic effects such as hypovolemia and shock. Nobody likes that. Shock's a preemptive to being dead. Loss of containment in the capillary, venous, and arterial systems. So do we know where the bleeding's coming from? Can we control those individual systems? Can we control those things anatomically or locally? Is there a simple way of doing that without jeopardizing the whole of the limb function? It's usually traumatic, some sort of breach of the capillary, venous, or arterial system, but not always. Sometimes it's coagulopathic. We rely on our natural physiological clotting ability to control bleeding. But in some circumstances, that's gone awry and it doesn't work anymore. We're not able to contain or control that bleeding, coagulopathic. And in that situation, there's no question that we need to sacrifice some of the tissues to control the loss of blood. Ischemia, on the other hand, is an anatomical obstruction of the flow to that end organ. So if we block off the blood supply, cellular metabolism is changed. Oxygen supply, nutrient transport, waste transport, all these things are disrupted. So by blocking the blood flow to that area, we interrupt the cellular function. Infarction is a situation where that has gone to the extent where there's tissue death and necrosis. Once again, we're reminded of our mortality. So by blocking the blood supply, the end point is those distal tissues die. So ischemia implies a reversal damage to tissue. So that's something, if we can reestablish blood supply, then those tissues can recover. That's the hallmark of the hand surgeon. We're going to reestablish blood supply, we're going to use microvascular technique, we're going to reestablish that blood flow to those tissues. But as soon as they're dead, irreversible changes have occurred, infarction occurs, our job is finished. So as long as we can maintain some blood supply, there's reversible damage, then there's an opportunity for reconstruction. We can decrease that zone of injury. There's many papers and many different philosophical academic things that we can talk about. Different tissues are vulnerable at different rates to ischemia, loss of blood supply. Pressure effects are different in different tissues. Some tissues, depending on a metabolic situation, some tissues can respond better than others. We can resuscitate those tissues. That's not really our discussion today. We want to get away from the discussion of ischemia and infarction, and we really want to talk about those things we can do to minimize that zone of injury. Is there some way that we can prevent the conversion of a hemorrhagic physiological situation from turning into infarction? Is there some way that we can stop bleeding without making it a necrotic, dead situation? I think this guy's got it right. Do as little as possible, but as much as is necessary. By poking his little finger in the dike, he saved the whole city. The anatomy of the upper limb is not that difficult. We can control the venous, we control the anatomy of the arterial system, we can control even bleeding from the muscles easily by direct pressure. It's not that difficult, but you need a sophisticated knowledge. It's not something that a layperson may do. However, direct pressure over the bleeding point is a very good start. Proximal placement of a tight tourniquet on a limb will cause interruption and flow of blood indiscriminately to the total limb. If we do that, all the tissues are ischemic. The more distal the tissue, the more effect that ischemia will have. Let's digress a little bit in terms of upper limb. So in the upper limb function, how magnificent is the hand? The thing that we use to connect with the universe, the precious value of the tips of your fingers, precious value of the thumb. How precious is the hand in comparison to your foot? These are some documents that we use in impairment ratings, particularly with workers' compensation situations. What are the relative values of these different tissue parts? If a patient is injured, they lose a portion of their hand, how do we value that in terms of the total person function? And you can see these are well accepted. In fact, these were initially started in the 16th century. But these are well established all the way around the world. And you can see that in the upper limb, 90% of the upper limb function is in the fingers and metacarpals, and particularly in the thumb. So 90% of the upper limb function lives in the hand. Sorry to some of my other partners, but the shoulder is just not all that important. However, in the lower limb, most of the lower limb function is held in the hip. Long John Silver, pretty competent. These are the same diagrams that we use for impairment ratings in the lower limb. And you can see even with an amputation of the foot, that's about 18% of the person. In my previous slide, amputation of the metacarpals is about 50% of the total person. But in the lower limb, not so. So now we need to make some judgments. Are they bleeding from the lower limb or are they bleeding from the upper limb? So once again, I'd just like you to consider all those things. The distal portion of the upper limb is so precious that the indiscriminate use of a tourniquet high on the arm jeopardizes those things that we hold most precious in the upper limb. In the lower limb, the volume of blood is high, and the situation where you might lose your foot is actually about 18% of the person. So in the lower limb versus the upper limb, we need to make some judgments. But generally speaking, we're trying to preserve those structures. We want to stay away from the ischemic situation. We want to give the hand surgeon a chance to reconstruct those tissues by not causing indiscriminate ischemia. So once again, we go back to our overarching algorithm. There's no question, if we need to save the person's life, we should do that first. No question. And there's good evidence that using tourniquets in these particular sorts of circumstances saves lives. However, if the life is saved, if the patient is in a situation where we don't have to worry about the immediate loss of their life, then limb function becomes important. And I would say upper limb function becomes of primary importance. Furthermore, we need to have a strong understanding of what portion of the upper limb, what portion of the blood supply, what portion of the thumb or finger. These are all the intricacies of reconstructive hand surgeries. There will be blood. If we are alive, you've all been waiting for this slide actually, if we are alive, there will be blood. And we have an emotional attachment to bleeding and other people's blood. It controls our emotional responses. But the blood is important. It protects us from ischemia and protects us from infarction. So let's address that in a more sophisticated and nuanced way. Remember that applying a tourniquet is not benign. It's not the color of the tourniquet. It's not how sexy or trendy it is. It's an indiscriminate way of causing ischemia in the whole distal part. And it has these effects, not only applying the tourniquet, but releasing the tourniquet. These all are complicated effects of that global ischemia. The Stop the Bleed program is very important. If you do these things, you will save lives. But there's a hierarchy of treatments. Direct pressure, apply a dressing. If necessary, you can apply a tourniquet. And if you really have to, put 2 on there. I was joking, don't do that. So these are the 2 points, the 2 principles. So let's try and decrease the zone of injury. Let's not do anything bad. Let's try and preserve that function. Let's try and stay away from ischemia and infarction. Let's make some judgments about, is the patient's life secure? Then let's concentrate on how sophisticated we can be to preserve their hand function, because the distal part of the upper limb is crucially important. If you can save their thumb, their index finger, a portion of it, that's very important in terms of that person's life function. Hemorrhage is not the same as ischemia. It's not the same as infarction. And once again, upper limb function lives in the hand. Thank you. So Dr. Benz is going to come up, so you guys have all got to get your papers ready and stuff. But I could answer a question if there was a question, or if anybody else, had something they wanted to say. Yes? Quick clot? Yeah, that falls into those categories. What can a lay person do in that circumstance? Direct pressure over the wound, an appropriate dressing, tourniquet as a 3rd tier. And quick clot does, once again, what do you have on you? Do you carry a tourniquet so that you can just jump right to that one? Or do you use your T-shirt? Do you put direct pressure on the wound? And quick clot's a good option for that, direct pressure over the wound. And I think if we spend our time doing that, we would not jeopardize any of the things that we can do in terms of reconstruction, and I think it would help the patient a lot. Thanks for your attention.